And I'll repeat that so you can all hear. There are handouts at the front of the room. If people can grab them, it will save us some time. And we're still waiting, even though we're running a little late. We're waiting because this is a very important presentation. Some people were a little confused, thinking workshops were next. No, this is the auditorium plenary. There will be workshops after this plenary session. And we're trying to move as many people in here as possible. And if you're going to stand somewhere, you probably don't want to stand where I was. It's better here. So I'm going to give it about half a minute. Someone is looking for a brown bag, CIT bag. Okay, we found it. Oh, there's lots of... So again, those of you who have just come in, we have handouts at the front. This is a really important topic. And those of you, how many of you attended the plenary with the insurance commissioner? Okay. This is the next piece you really need to know about, okay? So maybe we could put the handouts up at the back as people came in. Okay, well, I'm going to start by introducing, there's still people coming in, but those of you who don't know, I'm Kate Farrenhold. I'm the Executive Director of NAMI Maryland. We're really pleased to have you. Some of you came in a little bit later. We did have several plenaries this morning, which were pretty, I think, pretty fantastic. We had criminal justice, including the Secretary Green, and then we had the insurance commissioner, Al Redmer, and his outreach person, Joy Hatchett. I am pleased to introduce our next speaker, Ellen Weber. She is a lot of things. She's the Vice President for Health Initiatives at the Legal Action Center. It's a law and policy organization whose mission is to fight discrimination against individuals with histories of addiction, HIV/AIDS, or criminal records, and to advocate for sound policies in those areas. She is very actively involved in the center's efforts to improve access to comprehensive substance use treatment at both state and federal levels. She's done a lot of work in civil disability rights legislation, and she's got, if you want to read more about her, I know that there's more in the program. I first met her before she joined the center. She was professor of law at the University of Maryland Carey School of Law. And she established and directed from 2002 to 2017 the Drug Policy and Public Health Strategies Law Clinic, where she worked with students on disability rights litigation, legislative advocacy, implementation of the Affordable Care Act, and the Insurance Parity Act. Insurance parity is a word that many NAMI people know, but it is not a commonly defined term. Parity means basically equality and equal treatment. And when we talk about insurance parity, we talk about this long, long fight that some of us have been involved in, some of us even longer than others. Janet Edelman, sitting there, and several other people, been working on parity legislation from the inception of NAMI. And it is about not only getting the right laws on the books and the right regulations, but making sure that they're enforced. Ellen is the director, or I don't know what you call yourself, the director of the Parity at 10 Coalition. The Law Center chose 5 states to create Parity at 10 coalitions. And Ellen, thank goodness, came back to Maryland to lead the effort in Maryland. And a lot of our organizations are involved in the Parity at 10 Coalition. It is extremely important. And without further ado, I'm going to have Ellen talk to you. Thank you.
And thank you, Kate, for your kind introduction, and thank you for coming back to your second round of insurance discussion, I guess, today. I was so appreciative of Commissioner Redmer and Associate Commissioner Hatchett's explanation about what the MIA, the Maryland Insurance Administration, does and how you file complaints, because that then gives us an opportunity to really dig in a little bit more to really putting the Mental Health Parity and Addiction Equity Act into that context, and to talk a little bit about how that framework either does work or really doesn't work that well for parity enforcement, and some of the efforts that we're doing in this state to try to improve that enforcement. Certainly with the significant help and support of NAMI and the folks in this room and a lot of other partners in Maryland. So what I'd like to do is sort of three things in the next, hopefully, I guess, about an hour, maybe a little less. What I want to do is talk a little bit about Parity Act protections and common violations so that we reinforce everybody's knowledge about this area, this important law. Talk about enforcement barriers, and then talk a little bit about the initiatives that we're engaging in Maryland to try to improve enforcement of the Parity Act. And that includes education, so both of individuals and providers and policymakers. It involves regulatory activities and then some legislative advocacy as well. So I'm going to cover these three areas. I'll break it up a little bit, get your questions. There were some terrific questions that came out this morning that fit directly with what we're going to talk about. I'll try to answer those in a slightly different way than Associate Commissioner Hatchett did, and hope to have many more questions as we go along. So the Mental Health Parity and Addiction Equity Act is one of those laws that, as Commissioner Redmer mentioned, he has to enforce that law. And carriers in this state have to adhere to that law. So it's one of those laws that govern the contracts that each and every one of you in this room buys if you buy plans that are regulated by the state. So the Parity Act, as many of you know, it's a civil rights statute. This is a law that was passed 11 years ago. Just last week, we celebrated the 11th birthday of this incredibly important civil rights law. But its goal really was to end historic discrimination in insurance coverage on the basis of mental health and substance use disorders. The law applies very broadly. It applies to private health insurance, whether you buy that on the health benefit exchange or whether you get that from employers. And it also covers health coverage under Medicaid and the Children's Health Insurance Program. As Kate mentioned, the Parity at 10 campaign is an effort to recognize that this law has been around now for more than 10 years. When we started the Parity at 10 campaign, it was a law that was coming into right before its 10th birthday. We are now at its 11th birthday, and we have a lot more to do. But the goal was to try to increase understanding and awareness of this law so that we could advocate for better enforcement. And that was engaging consumers, providers, and policymakers. So that's the effort that we've been involved in Maryland, and really would love to have all of you participate in that. So this is essentially the essence of what the Parity Act means. It means that insurance coverage for the treatment of brain disorders must be equal to the insurance coverage for treatment of physical health conditions. That said, everyone must know about this law in order really to make it effective and to make sure that it is actually enforced, right? And so years ago, the national NAMI had done some surveys to try to find out what the level of awareness was among consumers about the Parity Act. And they found out that, unfortunately, there was a low level of awareness. In our Parity at 10 campaign, we again conducted surveys both of consumers and providers to find out what the level of awareness was. How well can folks enforce their rights? So in Maryland, a number of people, maybe some of you in the room, responded to this survey. And what we learned was that about half of the respondents, in fact, had never heard of the Parity Act, right? 49% didn't know that folks, that they had the right to equal mental health and substance use disorder benefit coverage under federal law, right? And another 11% weren't really sure about that right. From the provider's perspective, we learned, though, that at least 68% of the providers who responded thought that their patients actually had insurance problems. So again, there's this tremendous disconnect between individuals not getting what they really are entitled to in insurance, but not really understanding what their rights were. The providers obviously are a critical part of enforcement, in part because they have rights under the Parity Act, and we'll talk a little bit about that. It comes up in connection with this network adequacy, right? There are lots of questions about how do I get a provider in this state, right, in my network? Well, the Parity Act has something to say about that. And so providers not only have rights under the parity law themselves, but on a daily basis, they are asked to assist their patients in order for them to help them get access to their services. But in fact, what we learned in our survey was that providers also, about less than half of the providers who responded really couldn't respond, didn't know the correct answers to some very basic questions about parity rights. So again, these surveys demonstrated a real need to increase awareness. So for the next few minutes, let's talk a little bit about what the Parity Act does, and then I will answer questions so that your experiences can be brought into this conversation. So essentially what the Parity Act says is that if a health plan covers and provides mental health and substance use disorder benefits, that it has to cover them at the same level as benefits for other medical conditions. And that means that has to be equal benefit coverage and equal access to mental health and substance use disorder benefits. Now, the Parity Act itself doesn't require any health plan to cover mental health or substance use disorder benefits, but there are a lot of other laws that do. The Affordable Care Act, for example, identifies mental health and substance use disorder benefits as an essential health benefit. That means for individual health plans and small group plans in the state, they have to cover mental health and substance use services, and they have to do it at parity. In Maryland law itself has what's called a mandated mental health and substance use disorder benefit. It is a benefit that covers outpatient services, inpatient services, as well as residential care, prescription drug benefits. And so because the state law covers those benefits in individual plans, small group plans, and large employer plans, that means the Parity Act applies, right? So we have a very good foundation in Maryland law to apply the Parity Act, and we just need to make sure that in fact, that's what's happening. So just want to show you very quickly, to give you an idea just how broadly this parity law applies. Now, people across the country, individuals get their insurance in many different ways. Some, as in Maryland, buy them on the health benefit exchange. Some get them from their employer. They may have a small employer that offers those benefits. They may have a large employer that offers benefits. They may be part of a public employment system, right? They may get them from Medicaid, Children's Health Insurance Program. Well, if you look at this chart, what you'll see is that in virtually every one of these situations, the Parity Act, either as a result of state law or a combination of state and federal law, all of those plans are subject to the Parity Act, right? So under those plans, you have the right to have equal access to benefit coverage, as well as equal access to those services. Now, there were some questions this morning about Medicare. Well, unfortunately, Medicare is the one type of health plan that is not subject to the Parity Act. That is sort of what I call the last frontier of coverage. So many individuals who have plans up to the age of 65, at the point in time when they become Medicare eligible, they do not have these same rights. TRICARE, and if any of you have been in military service and are still insured under TRICARE, TRICARE is another type of health plan that isn't subject to the Parity Act. Now, there have been many amendments to TRICARE coverage that bring it closer to the parity law, but in fact, it's not quite covered. The other thing to know about public employer plans is if you have a non-federal employment plan, a state or local government employment plan. Those are plans that are allowed to opt out of the coverage of the Parity Act. Not many do in Maryland, but they are permitted to. If you work for the federal government, by executive order, is subject to parity protections. So as you can tell, most of the plans that either you, your family, or the patients who you serve will probably be subject to this law, okay? Now, let me talk just briefly about what it is the Parity Act does. What kinds of protections are in existence? Well, these are the things that you see all the time in your health insurance plan, right? Out-of-pocket costs, right? So under the Parity Act, these kinds of out-of-pocket costs, which under the law are called financial requirements, are subject to protection. That means your deductibles. It means your co-payments. It means your co-insurance and your out-of-pocket maximums, right? So you have a co-payment of $30 for every time you see a therapist. You go to a drug treatment program. That standard is subject to the Parity Act. If your plan requires you to pay co-insurance, then that is also subject to the Parity Act, all right? Limits on the length of treatment, right? These are called, in a very kind of weird term, these are called quantitative treatment limitations. And what you know these as is, if you ever saw a plan that had a limit on the number of visits that you could get under your insurance plan, like 15 outpatient visits a year, that's what's called a quantitative treatment limitation, and that is covered by the parity law. The number of days of coverage, for example, you would get 14 days of residential treatment. No more than that. It was written into your plan. That's also now subject to the Parity Act. Something like the frequency of treatment. Well, you can get 2 episodes of treatment every year, but that's all this insurance plan is going to cover. That is also something that's covered by the Parity Act, right? There are other kinds of limits that you are very, very familiar with that limit access to the scope of treatment or to limit your access to that treatment. But they aren't identified so much as a hardline quantity, but by their very operation, they can limit access to treatment. So when you take a look at your insurance plan and you look at what benefits are actually covered, do they cover residential treatment? Do they cover intensive outpatient services? How about partial hospitalization? Well, to the extent that a plan limits the coverage of mental health and substance use disorder benefits, that's one of these plan design features that are subject to the law. These are called non-quantitative treatment limitations, all right? The questions that came this morning about network adequacy, right? Can I find a provider in my network? What about the reimbursement rates for providers, right? Those are all plan design features that, because they can limit access to mental health and substance use disorder care, they are covered under the parity law. Okay, and we're going to talk about how that fits into your experience, but just keep in mind that these are plan features that are all subject to this non-discrimination standard. Sometimes there will be situations in which you may be required to try one type of treatment before you're authorized to get another type of treatment. This is called step therapy. Sometimes it's called fail first requirements. Those are utilization management standards that are also subject to the Parity Act. How about if your provider says, you need to get authorization for this care before we're allowed to treat you? Or after you're in care, you have to get continuing authorization for services, whether that's every 2 weeks, every 7 days, every month. Those are, again, utilization management standards that are all subject to the Parity Act, all right? So when you take a look at this list, it's just about every single thing that makes a difference in terms of whether you're getting access to care or not. all right? These are all subject to this non-discrimination standard. Now, the big hitch in this law is, how do I know whether there's discrimination, right? How do I know if my plan is doing something that it is not allowed to do under federal law? The biggest problem with regard to the Parity Act is not what its intention is, not what its goal is, not that it isn't widely expansive. It's that it's very difficult to enforce. And the reason it's difficult to enforce is because what it requires is, it requires a comparison of the coverage of the mental health and substance use benefits with the coverage standards on the medical side. Now, as a consumer and as a provider, you well know what's happening on the mental health or substance use disorder side. You see what the benefits are in your plan. You see what your provider is asked to do. You see what what the limits are that are imposed on you. But very often, you do not know what the comparable standards are on the medical side. And because of that, it makes it difficult for you to file that complaint with the insurance department, right? That's one of the reasons it's difficult, because you, quite frankly, don't have the information that you need in order to know whether there's actually been a violation. So what you can do, however, and part of the materials that we've provided, and we'll talk about them in a minute, are you can identify red flags. You can say, something doesn't seem right here, right? For example, I have to pay $40 in a copay every time I go for one of my visits to my therapist, right? But when I go to see my primary care physician or another specialist, I'm not paying $40 per visit. I'm only paying $20 per visit, right? That should throw up a red flag. It may not be a violation, but it is suspicious, all right? It's suspicious because, again, remember, mental health and substance use treatments are supposed to be provided in an equal fashion as medical services, all right? Same thing with these visit limitations. If I had maybe a 15-visit limit for outpatient counseling, but there is no limit on the number of sessions I can go to see my endocrinologist for a condition of diabetes, that should be a red flag, all right? So those are the things that you can do on these quantifiable limits, right? These cost sharing, these out-of-pocket costs, or these treatment limitations. That's one of the ways to flag those problems. Does it look right or wrong, all right? For these types of access coverage issues called, as I said, these non-quantitative treatment limitations, there are also red flags for that, right? How about if you're required to get a lower level of care before you get the requested services? That should throw up a red flag, if in fact that's not happening very often when you seek medical services. How about if residential services are excluded, right? If you look at your plan, residential services are excluded from mental health or substance use disorder services, but you could actually get skilled nursing facility services for a medical problem. That should throw up a red flag. How about if it feels like you're getting prior approval or being required to get prior approval or approval for continuing care on a very frequent basis for mental health and substance use services? But it never seems that way when you're dealing with another chronic health condition. That too should be a red flag that alerts you that there may be something wrong, okay? Here are some other ones, and these get to some of the questions that you were asking earlier today. How about if you can't find a network provider, right? Or how about if there's a 6-month wait list? Well, in a few minutes, I'll tell you there are some additional protections in the law around that, but I will also say that that's a red flag. That is a red flag for parity violations. How about as a provider? If you are a provider and you are being given incredibly low reimbursement rates as the contract rate for your services, and you think, my God, I can't survive on this. I can't believe medical providers are paid this same rate. Well, that disparity in rates exists. There have been several studies that demonstrate that psychiatrists are paid much lower than primary care physicians for the exact same evaluation and management codes. That is a parity violation. But it still continues, and we have even more recent data in Maryland that it's continuing to happen. Those are parity violations that should be resolved. Those are parity violations that, if resolved, would probably go a long way to fixing carrier networks and the number of providers who are available in those networks, okay? How about if you see some restrictions on where you can get care? You could go out of state for services for medical care, but you cannot go out of state for mental health or substance use disorder services. That's a red flag. That's probably a parity violation. How about if there's a particular setting? You can't go to residential services for mental health or substance use disorder services. You could go to an inpatient hospital setting, but not a residential service. But, as I said, on the other hand, skilled nursing facilities, non-hospital-based, 24-hour services are covered. That's a red flag for a violation. And how about if you're looking for your coverage of your medications, but your medications are all on the most expensive tier of the formulary? Again, probably a red flag that there's a parity violation out there, okay? So you will not know, as I said, you will not know whether there are actual violations, but you can be pretty darn sure that if you're seeing disparate practices, there may be some underlying problem. Right? Now let me run really quickly through some violations that the federal government has identified, just so that you have an example that you can, again, compare to what's happening in your own coverage. So, for example, if methadone treatment is covered for pain treatment under a plan's formulary, but that plan covers no opioid treatment programs that dispense methadone for substance use disorders, the federal government has said that's a violation. How about if their out-of-network residential services are not permitted for eating disorders, but they are permitted for other medical conditions? Federal government has said that's a parity violation. For prior authorization, here's the example where there were some plans that would require authorization after 1 day of treatment, again, based on a treatment plan. But for medical services, didn't have to get prior authorization or submit a treatment plan until you've had 7 days of treatment. Federal government said those aren't comparable. That's a parity violation. Step therapy. How about if you're required to try outpatient services twice before you're given access to residential treatment, but on the medical side, there's only a requirement that there be one unsuccessful effort at outpatient services before residential care is provided. Government says that's also a parity violation. How about with the last one on dosage limitations? For buprenorphine, some health plans impose dosage limitations that are lower than nationally recommended standards, but they don't do that for other medications used to treat medical conditions. Again, federal government says that's a parity violation, right? They also have now provided some very good guidance on reimbursement rate setting. Here's an example where a plan reduces the reimbursement rate for non-physician practitioners for every billing code on the mental health and substance use disorder side, but they don't do that same reimbursement reduction on the medical side. Again, those aren't comparable practices and standards. That's a parity violation. Here's one that's very familiar to us in Maryland, right? Carrier networks. Carriers have metrics to decide whether the network is adequate or not. When they see that they have an inadequate network for medical providers, they boost up the reimbursement rate in order to meet their metric. But they don't do that for mental health and substance use disorder providers. They don't do that to boost up the number of providers in the network. That's a parity violation. And for provider directories, it's one that all of us have felt and noticed. These directories are out of date, and they have inaccurate provider information. What the federal government says is that is a violation of federal law, right? So all of these are items that should be complained about, right? There's other ways of addressing them, but if you've run into that, these are situations in which you should be complaining to the Maryland Insurance Administration. Now, on this part of the slide, I want to talk to you a little bit about some of the violations for networks that the Maryland Insurance Administration has actually identified. If you remember this morning, Commissioner Redmer said that they often do investigations of health plans. They go in, they look, they see whether there are violations. Well, as a result of the work that the Maryland Parity Coalition has been doing, the Maryland Insurance Administration was required to do these investigations, to look specifically at whether there were parity violations. And so what they did was they dug in very deep on network issues because they heard a lot of complaints that consumers were having a lot of problems finding in-network providers. And what did they find? They found a lot of violations. Just this year, they found that Cigna refused to admit 5 out of 13 substance use disorder treatment programs because they claimed that there was no network, there was no need for that in the network. They also said that there was no need in the network for more medical providers, but do you know what? They admitted all 122 medical providers to their network, even though they said our network was full. We didn't really need any more. That's about as disparate as you can get. That was a parity violation against Cigna, all right? Aetna. Aetna's another example. What Aetna did that's a violation is that to credential mental health and substance use disorder facilities that worked with adolescents, they required them to go through a very detailed personnel review. They didn't impose that standard, however, on any medical facility that treats youth and adolescents. MIA found that's a parity violation, right? Care First. Care First, back in 2018, was found to have not accurately identified residential and non-hospital, hospital and non-hospital facilities in its directory. The MIA penalized them because that was a violation of the law, right? And you can see several other violations that have been found by this state, all righty? And I would venture to say there are many more that are out there. Now, let me talk very quickly about these network adequacy requirements, right? Because this morning, Commissioner Redmer told us all that after 2 years of monitoring what the carriers were doing with regard to building their networks, yet again, the carriers did not comply with these standards, and he said he was incredibly disappointed with their submissions. Well, here's an example of just how bad those submissions are, right? There were 16 carriers that submitted network adequacy reports. The appointment wait time metric is one of probably the most critical to patients who want to get into care. And under the regulations, the standard is for urgent mental health, substance use, and mental health, substance use, mental health, and medical services, providers are required to provide urgent care within 72 hours for 95% of their enrollees. Okay? Only two carriers reported that they satisfied that metric. Care First Blue Choice and the Kaiser Foundation Health Plan. Only two. If you take a look at non-urgent mental health and substance use disorder services, again, the metric there is carriers have to allow patients to have an appointment within 10 days. That's for, again, 95%. If you take a look at this list, many of the carriers simply did not satisfy that. The largest carrier in this state, Care First, could only satisfy that metric for one half of its enrollees, right? Cigna, 76%, Aetna, 89%, right? Those numbers translate into whether or not we get access to care when we need it, right? And as Commissioner Redmer said, under the law, if a carrier doesn't satisfy these standards, they're allowed to ask for a waiver. Only one plan, Care First, asked for a waiver. But you know what? They didn't satisfy the requirements for asking for that waiver. The reason what the regulations require is carriers, if you ask for a waiver, you have to show us what you did to try to build your network. You have to show us and tell us how many carriers, how many providers you tried to contract with, and tell us why you weren't able to enter that contract. What that does is it gives us a whole lot of information as to where the gaps are. It gives us an understanding of whether there just aren't providers or whether, in fact, it's because the carrier doesn't want to pay enough, right? Or whether the carrier basically just says, we're full and we don't need more substance use or mental health services. CareFirst didn't answer any of those questions, and none of these other carriers that didn't satisfy this metric answered those questions. So again, year 2, we are in as big of a uncertainty as we were when when we started out this initiative. Yes, so there's a question back there, and I'm actually right at the point where I'm going to open it up for a few minutes of questions. Yes, sir.
On your last slide, is there any, the two providers that seem to do the best with the access to urgent care seem to do the worst with the access to non-urgent care? Is there any indication why that might be?
It's a very good question. And one of the issues, and we're going to talk about that in a minute, about how do you really get good enforcement, right? One of the problems is consumers do not have access to the answers to those questions. Now, some of that information may be provided by carriers to the Maryland Insurance Administration as it's conducting its investigations. But the Maryland Insurance Administration is not making that information public to consumers, okay? And so as a result of that, and it's not making it public to providers either. And so as a result of that, we are in the dark as to why these kinds of disparities exist. And we're in the dark as to what some solutions could be, right? Because if we knew why it was happening, then as a policy development matter, we can create some solutions. We're really at a disadvantage around that. But there are some strategies, though, to address that. We're doing that, trying to address those through these strategies in Maryland, and we will talk about that, okay? Other questions, yes?
And when you're speaking about networks, are you talking about like HMOs opposed to PPOs? Like the PPOs can go anywhere.
So, yes, so certain plans are health maintenance organizations, HMOs, that have a network of providers. So when I talk about a network of providers, I'm talking about the network that HMO has. For a PPO, for a provider organization, again, they have a network as well, and they often allow consumers to go out of network for services. But it is those lists, right? The person who asked the question this morning about, I've run through the in-network providers that are listed in my directory, and none of them are taking new patients, right? It's that list that I'm talking about, that list of providers that are there to provide those services and that are either available or not available, all righty? So in response, though, to that question this morning, and I just want to give you an additional response, right? There was a question that said, do I have a right to get services under my health plan, right? In order to get care. Again, within 10 days under the Maryland law, if it's a non-urgent service, or 72 hours if it's for urgent care. Do I have a right if my carrier doesn't have a provider? Yes, you do have a right, right? In addition to filing a complaint, what you are allowed to do under Maryland law is you are allowed, if a carrier cannot make services available to you within a reasonable time or distance, and this is what defines that reasonable time, you can get approval from them to go to a provider that is a non-network provider. That is your right. That is your right. And again, it's not one that was mentioned this morning, but it is one that you have, and it's an important one to exercise. And I'm going to talk in a few minutes about some legislative work we're doing around that. Let me answer one more question, and I'll be right to you. The other question was, how do we increase these networks without without that being translated into higher premium rates, okay? What you should be thinking about with regard to that is, these are federal standards that the carriers are making representations to you that they are already satisfying. And they're supposed to be satisfying them at the premium rate that they are charging you now. So if they're saying to you, the only way we can come into compliance with this law, which they say that they're already complying with, is by raising your premiums, then I would venture to guess they are selling a fraudulent product right now, right? Because they're making a representation to you that they comply with the Federal Parity Act. They're not allowed to sell these plans in Maryland if they don't comply with the Parity Act. So if they're saying, I'm sorry, the only way we're going to be able to come into compliance with this law is increasing your reimbursement rates, I do not think that is an answer that is legal, all right? All right? And I think that is a response that we, again, need to be taking to legislators, need to be taking these back to the regulators, all right? Your question.
Okay, so there's an appointment wait time metric for the first visit within 10 days, but what about continuing care? Like you have counseling, and you're supposed to, the recommendation is once a week or once every 2 weeks, and nobody's available for 6 weeks. Is that a violation?
I think that would be a really, yes, I think that could be construed as a violation. That's your appointment wait time, and it doesn't say, I don't believe, I've got to go back and look at the law, I don't believe it says for the first appointment. No, it's appointment wait time, 10 days. Okay? Now, this again, remember, appointment wait time, I mean, again, there are going to be problems, obviously, in terms of sometimes always, adhering to that. But again, you should not be facing those kinds of wait times in order to excessive wait times in order to get your care. Okay? Yes. We do not have this information by county. We do not. I don't know whether it was collected by county or not. I do not believe it was. There are the other two metrics that are required are wait time metrics, the appointment wait time metrics, provider to patient ratios, and then there is a travel distance requirement. That is the requirement that differentiates between geographical regions in our state. And so in urban areas, the travel distance metric is a smaller travel distance than it is in rural areas. That's the only thing that distinguishes by geography. All righty? All right. Any other really pressing questions about these standards? Does this begin to make some sense? Does it fit into your experiences? And do you see how maybe some of these rights might help you access the care that you and a loved one needs? I hope it's beginning to, okay? So let's talk a little bit about what the barriers to parity enforcement are. And the reason it's important to first talk about the barriers is because once we identify the barriers, then we can really identify what some of the solutions are, right? So what are the enforcement barriers for consumers, right? Well, the first one is they don't get complete information, right, in their insurance policies, right? They don't know about their parity rights. They don't know what the requirements are going to be for getting care authorization. So when the commissioner talks about his staff reviewing insurance plans to see whether they comply with the law, they review the plan features that are available on the face of the plan. But if there's a whole lot of standards that the carriers don't put on the face of the plan, they can't review them, right? And that's really what's happening. So neither the consumers nor the regulators have all the information that they need, right? Again, some of the other results from our survey, the consumers simply lack awareness of what their appeal rights are, and they need assistance, particularly in the time of crisis. One needs assistance to help you understand this complicated law, understand your rights, and to exercise those rights. So those are the barriers for consumers. They don't have the information they need, and they need assistance, right? The other issue with consumers is these are not, with an individual complaint, it may respond to that one person's complaint. It doesn't address the systemic issue. And most of these violations are system-wide. They are plan-wide violations. And so they should be eliminated plan-wide, not consumer by consumer, right? If you take a look in your materials, this is one of the other standards that the Parity Act provides for. You as a consumer have the right to certain information. You are allowed to get the medical necessity criteria, and to do this comparison that's required, you can get medical necessity criteria as well. You are entitled to the reasons for the denial of coverage. And in the context of the denial, you can ask for all of these documents that establish these standards that may raise parity violations, all right? Those are your rights. I can tell you, though, from experience, when you begin to ask for all of those underlying documents that establish the parity standards, the carriers are not inclined to give you that information. They just don't do it. All right? So that's another problem. You cannot get the information. So when the MIA says file a complaint, it's hard. It's very hard for you to do that because you don't have the information. And I have seen situations in which the Maryland Insurance Administration has asked the carriers for that underlying parity information, and they don't give it to the MIA either. So it's difficult to enforce in this way. And this is all leading up to what our real recommendations are for how you have to get better enforcement, all right? What are the obstacles for providers? This is information, again, from our survey, right? If we are relying on providers to help patients enforce their rights, the providers many times just find that too time-consuming. They have many other things that they're supposed to be doing, including providing care, right? Others responded that this simply wasn't their area of expertise. They lacked the resources to help them do that. They also identified that sometimes they did file complaints, and those efforts were not successful, so that was a disincentive for doing it again. And many of them just simply didn't know what to do. So again, some of our education efforts, some of the materials that you have, that education toolkit that we handed out, that's designed to help providers and consumers at least understand the basic rights that they have so that they can do a little bit more in terms of enforcing them. So as a result of what the lack of ability to assist consumers, our survey also asked providers what they generally did when a patient of theirs didn't get authorization for the services that the provider said were necessary. So at least a third of the providers said that they filed an appeal with the carrier, or that they encouraged their patients to file that complaint. Some of them attempted to negotiate with the carrier. A lot of them, however, used other resources to provide the necessary treatment, right? They found that to be more expeditious and necessary in order for patients to get the care they needed. I would suggest that that happens a lot, and what that also then means is that shifts the cost, right? It shifts the cost from what the carrier is supposed to be providing and paying for, based on the premiums that we all pay. It shifts those costs to the providers, and it shifts those costs to consumers. And that's why, in addition to not getting the care that you're entitled to, it is an unfair system that should be addressed, right? Many other care providers simply accepted the level of care that was authorized. Again, not sure that that is particularly helpful for patients who need a particular level of care in order to really to bring their health back to where they need it to be. It provides some care, but it may not be the care that is the recommended care, right? And finally, what are the barriers for insurance, for the insurance carriers themselves, right? Limited transparency, we already talked about this. They don't get the plan, information that's needed to evaluate, whether there's parity compliance. So when the MIA signs off on a plan that says, this plan is good to go, we can sell this on the marketplace, right? Or you, Mr. Employer, Ms. Employer, can sell this plan, they are not evaluating probably 75% of the plan features that they need to be reviewing for parity compliance. They just don't review them. They review what they can review on the face of the document. And what they can review on the face of the document are those out-of-pocket costs, any kind of quantitative limit on care, and that is about it. And we have talked with them many times about that, but that's what's on the face of the document, all right? That, again, points the direction to where some enforcement reform can happen, all right? Complaints, we've already talked about it. Complaints, they're filed in the complaints don't get filed. Just too hard to have it happen. And with their post-marketing investigations, again, as we've seen, when they dig deep, they find problems. The problem is, though, it takes them 18 to 25 months to conduct those investigations. During that period of time, consumers have bought probably 2 different health plans, both of which probably don't comply with the Parity Act. All right? So therein lies the problem. We need something more proactive. For folks who know more, who work in the Medicaid system, we have some of those same problems. Under the federal parity law, Maryland Medicaid was supposed to file a report to show that it complied with the law as of October the 1st, 2017. They filed that report 18 months late. 18 months late. And what we were told was, again, to do this comparison, they had to compare what the managed care organizations did for medical benefits. They got incomplete data, so they couldn't do a good analysis. What happened as a result of all of the advocacy of the Maryland Parity Coalition, the Centers for Medicare and Medicaid Services, which approves Maryland's Medicaid program, has now put the state under corrective action to fix their parity standards, and they have to fix them by October 1, 2020. What most of some of the biggest outstanding problems are, the reimbursement rate setting, we believe violates the law, and there are some combination of services rules that we also think violates the law. There are prior authorization requirements for all mental health and substance use disorder services. We think that violates the law. There are not prior authorization requirements for all medical services. And then we think that there's some problems around benefit coverage, all right? Any quick questions about that? Because I am racing to get to where we think we need to go before Kate gives me the cutoff sign. Any big questions about these barriers? All right, then let me quickly talk a little bit about the Parity Coalition. Our strategies are to educate providers, consumers, and policymakers, right? There's the toolkit that we've identified for you. This provides some of that very basic education. It also includes very specific guidance on how to file a complaint for a consumer in both the Medicaid program and in private insurance. It's the 3rd and 4th page of this document. Please take a look at that. See if that's helpful to you. Please share that with other individuals, right? We're also engaged in a lot of advocacy and then some communications work. So let me go on and talk about those. This just identifies what's in that toolkit. The regulatory activities that are coming up. These market conduct surveys that we've just talked about, we are now reviewing the results of the 3rd survey. We are finding, again, additional problems that we're going to bring to the attention of not only the MIA, but also to the attention of legislators so that legislators can begin to take action. Remember what Commissioner Redmer said. Commissioner Redmer enforces the law, no more, no less. And if we think other actions need to be taken in order to make the law more effective, we have to go to the General Assembly. Well, what we are doing is we are taking all of this information that the MIA has gathered that shows rampant violations, and we are saying to the legislators, something more needs to be done to improve parity enforcement. And I'll talk about that in a minute. Commissioner Redmer also spoke about the network adequacy regulations, trying to tweak them and revamp them. Our coalition is going to be involved to make sure that the standards are not weakened, but in fact, that the the enforcement provisions, the enforcement tools are actually heightened, all right? And then with with Medicaid, many of you probably are aware that Maryland Department of Health is now undergoing a look at whether the Medicaid system should be redesigned, whether mental health and substance use disorder benefits should be carved back in to the Medicaid managed care. Many of us in the room are actively engaged in that to ensure that there's parity compliance. Here is the agenda. As I mentioned, we think that there are better ways of getting compliance with regard to the Parity Act. Just like any other regulated industry, we think this industry should demonstrate that it actually complies with the law before it's allowed to sell plans on the market. We have had legislation over at 3 different times to try to get the General Assembly to require carriers to articulate all of the plan features that are subject to the parity law and how they comply with that law, and to give that to the Maryland Insurance Administration for their review when they're doing their plan review. We've not yet been successful, but we're going to come back at it one more time. The commissioner also indicated that they're taking another look at the penalties. Well, right now, the penalties that they impose really are nothing more than the cost of doing business. So we have to get stronger enforcement of that, right? We have to get them to impose stronger penalties, and we have to get those carriers, when violations are found, to make a consumer whole again. That is not what's happening right now. The other thing that we've been focusing on is, how do you address this network adequacy problem, right? Under the law, consumers are supposed to have the right to go to a carrier to get approval to go to a non-network provider. But in those situations, even if they get that approval, they very often pay more out of pocket because they are what's called balanced billed. They are billed the difference between what the provider charges and what the carrier will pay for that service. We don't think that's fair. This is a service that should have been provided as a network service, right? You're supposed to pay a co-payment or co-insurance and nothing more. You are not supposed to be balanced billed. Last year, we tried to get a bill passed that would protect consumers against that. We weren't successful, but we're going to go back at it again, and we could use your help. Talking about your experiences, talking about why it's so important to your health and your family's health to be able to get the care that you need at the time that you need it and not go bankrupt in trying to do so. Okay? So, last slide. Here's what you can do to get involved. You can join the Parity Coalition. You can track the problems and let us know about them. If you're a provider, please identify where you think there are violations, and let's gather that information and make reports to both the regulators as well as to the lawmakers who can try to fix these problems. Thank you. I appreciate it.
So if you are part of NAMI, please go through NAMI Maryland before just joining the Parity at 10 Coalition so we can all be on the same page. But definitely, this is really important. It's going to be a large part of NAMI Maryland's, as always, efforts at the legislature, but we're doing a lot of work. Thank you so much for Ellen's work and for the whole Parity at 10 Coalition. And we have a lot more coming up. You have literally a 10-minute, break, or slightly less, and then we have 2 sessions of 5 choices of 5 different workshops each session. Please do try to take advantage of the workshops that are being offered. I know you all want to also talk to each other, but we'd love to make sure that the presenters actually have audiences. Last thing I wanted you to know is that a lot of these materials are indeed on the NAMI Maryland site, and anything that is in the auditorium is being recorded and will be posted as soon as we have all the on our website, as always, as well as the PowerPoints and resource materials handouts that are given out at the various workshops, as long as the presenters have given